Thank you, Dr. Salapandian, sir. Actually, as you rightly said, it is a very big task. But looking at the speakers after me, my task has become very simple because each of the speakers after me have their own individual assignments for perioperative period, ICU, so on and so forth. So, on that note, my task has become actually considerably simple. I've already committed to Dr. Mohan sir that I'm going to be very crisp. So I'm going to give you a bird's eye view on what is required for glucose control in a hospital setting, right? And all of us are aware that in hospital hyperglycemia increases not only morbidity but also has an effect on mortality and substantial health care costs, right? This is something that we are all cognizant of, right? Now, hyperglycemia in hospital setting comes in different forms. Could be overt diabetes. Patients could be having pre-existing diabetes. Diabetes can be first time detected only during hospitalization. Patients can have stress-induced hyperglycemia. Patients can also have hyperglycemia because of steroid exposure, isn't it? There are different forms and shapes of hyperglycemia in a hospital setting. However, the thumb rule is you need to get the sugars under control. Now, interestingly, only two scenarios, two circumstances, patients are always willing to listen to us. One is during pregnancy, right? When you suggest insulin, patients are willing to take insulin and they are more proactive than even us. And the other circumstance or scenario is when patient is hospitalized, right? Otherwise, routine type 2 diabetic patient, if the sugars are 300, you suggest them insulin, he'll tell us sugars was 500 last week or previous month, right? So that's the kind of approach patients have. Whereas in a hospital setting or in an ICU, patients want to know how the blood sugar is every 2 hours, even though they are on an insulin infusion, right? That's the irony, that's paradoxical. So, I mean, those are some of the challenges, but I think it captured people's imagination during the pandemic. The pandemic shed light that uncontrolled hyperglycemia has a worsening impact on COVID patients, right? We did an observational study. This was done in South India, including our hospital, during the second wave of pandemic. So we included patients who were diabetic or non-diabetic. These are data that we are all aware of. But what we learned is look at the baseline characteristics between patients who are diabetic and non-diabetic. And finally, look at the complications that diabetic patients developed, including acute kidney injury. And look at the bottom part. Mortality is almost twice in patients with hyperglycemic compared to non-diabetic, right? So if you tease out independent points, not only each of the complications, even the mortality, there was increase in patients with pre-existing diabetes compared to non-diabetic. Now, if patients have diabetes, but if you control the blood sugar, can it improve outcomes? Right? So I'm going to show you a meta-analysis, a systematic review of several studies, which was published a couple of years back, consistently demonstrated that improving glycemic control reduces hospitalization stay, length of stay, reduces the cost spent in the hospital, reduces the mortality. Right? Consistently it has shown. So there is no ambiguity, there is no brainer that patients who are admitted need blood sugar control. So as I mentioned, I'm going to give you only a bird's eye view, and then later on we are going to look at from individual speakers how we are going to approach each patient. Now, what are the reasons hyperglycemia can cause poor glucose outcomes, right? Uncontrolled blood sugar can increase inflammatory cytokines like tumor necrosis factor alpha, interleukin 6, and reduce patients' immunity. They can also increase a reactive oxygen species and result in mitochondrial injury. Right? These are the reasons. They can also cause oxidative stress, reduce nitric oxide synthesis, result in endothelial dysfunction, so on and so forth. Right? These are the mechanisms by which uncontrolled hyperglycemia can have poor outcomes. Moving on to the next part of my talk, of course, this will be deliberated by the subsequent speakers. As I mentioned, when do you suspect uncontrolled blood sugars? When do you suspect patients having diabetes? Is only when the patients have blood sugar over 140 is when you actually start suspecting. But today, I think in our city, the best way is to actually check a HbA1c. That's pretty straightforward, right? Whenever you have suspicion over 140, or even when patients have even normoglycemic levels on presentation, you still do a HbA1c, right? But if patients have had any recent blood transfusions, or patients have severe anemia or CKD, maybe sometimes HbA1c can be misleading. You would like to do other assays such as fructosamine assays, so on and so forth, right? But however, so what should be the glycemic targets for hospitalized patients, right? This has been a controversy for many years. First we had the Vanderbergs, and then subsequently Nice Sugar in 2009 demonstrated that blood sugar between 140 and 180 is better than even 100 and 140, right? You had an intervention arm where you maintained intensive glucose control. In fact, the arm which had a less stringent glucose control between 140 and 180 fared better. Quickly, professional societies globally started recommending a blood sugar range between 140 and 180. What are the inpatient glycemic targets? I think I've already mentioned this. Now, role of OADs in a hospital setting, pretty straightforward. In an ICU, you have multiple protocols, including the Yale School protocol, and then you intensify it based on different algorithms depending on patient's glycemic variability. OADs are generally not recommended, right? Insulin is the rule. But however, why OADs are not generally recommended? Metformin in patients where they could be having anaerobic metabolism such as sepsis, etc., it can trigger lactic acidosis. So of course, metformin is contraindicated. Glitazones can increase circulatory volume. Sulfonylureas are not reliable. They can cause hypoglycemia. However, sulfonylureas can be optimized. They can be gently used in certain settings where you would want to reduce your insulin quantum. And if you can balance it, probably you can, if you monitor, you can also avoid hypoglycemia. GLP-1 receptor agonist, there is some study showing that during perioperative period, you can use liraglutide in certain patients with established cardiovascular disease, coming out of atherosclerotic cardiovascular disease after after a PCI, you can actually use incretin-based therapies. SGLT2 inhibitors during concomitant infections or perioperative period, it can trigger euglycemic decay. Yeah, that's something that we've learned during acute infections. We are not supposed to give SGLT2 inhibitors. However, there are a couple of studies, Impel's study with empagliflozin and Dictate study with dapagliflozin have shown that we can use SGLT2 inhibitors in select patients who have fluid overload admitted with pulmonary edema. Even on day 2, day 3, SGLT2 inhibitors have actually improved mortality rates, improved even patients' symptomatic recovery. In fact, hastened patients' recovery. Patients who had fluid overload, you know how debilitating pulmonary edema can be, right? It has in fact improved the recovery in patients. So obviously in only select patients, otherwise SGLT2 inhibitors are generally not used, right? You have to remember that these are only for patients who are coming with fluid overload. We know these agents have shown superiority with heart failure, correct? But even in acute heart failure, now they are shifting the needle. That's the message I'm trying to communicate, but not in other set of patients, right? This again, you're going to see in the subsequent speakers, how generally you'll want to start insulin in lean patients, in moderately built, and in patients who are obese. You'll obviously like to increase insulin and then monitor and adjust titrate accordingly, right? Now, it's a controlled environment. It's not that patient is going to go away. So it is pretty easy. Now you have the CGMs, and you can use CGMs, of course, in a non-ICU. In an ICU, you wouldn't want to use CGMs. There is a Glucose Scout or other CGMs which can be used in ICU, not freely available in India. However, in an IP setting, it can be still used in certain patients who are not dehydrated, in certain patients whom are not septic, etc. CGMs can sometimes be used. So this is the initiating insulin therapy, and it is better to start basal bolus and not go to a sliding scale approach. Now, sliding scale approach has been condemned by all professional societies, but we still tend to use sliding scale because it's very convenient, right? The duty doctor, the house surgeon, or the budding doctor can easily use sliding scale. So the challenge with sliding scale is your reacting to blood sugar hyperglycemia, right? You're allowing the blood sugar to drift away, and then you're going and battling it, right? You're not being proactive. The other basal bolus is being proactive. You're not allowing the sugars to drift away. So obviously that has an impact. There is numerous amount of data to suggest that basal bolus is far more superior than sliding scale in terms of glycemic variability, in terms of also reducing the risk of hyperglycemia. And I would also like to quote another important study done by Melida in Spain. So she actually compared premixed insulin versus basal bolus and also demonstrated that premixed insulin resulted in 56% patients hypoglycemia, right? Whereas basal bolus, the hypoglycemia was lower than 24%. Imagine more than 50% of patients having hypoglycemia. You wouldn't want to give that kind of a regimen, right? So finally, the formula, the best would be a basal bolus. Some comments on patients who are admitted, who are planning for elective surgeries. Metformin can perhaps be withheld 24 hours prior. All other OADs can be withheld on the day of the surgery. Again, insulin is the norm. This is also something that we are going to see in the subsequent speakers, so I'm not going to elaborate on this. Discharge depends upon the patient's profile. If patients are newly diagnosed, of course, your response is going to be different. If patient is still sick, you might want to give insulin, and then the most important discharge advice would be any patient profile. You would want to monitor the sugar in 3 to 4 days, because patients may have glucotoxicity on presentation. At discharge, after 2 to 3 days, patients, if the infection is under control, if the glucotoxicity reduces, patient can actually land up in hypoglycemia, right? So you would want to monitor your sugars 2 to 3 days, irrespective of whatever reasons they were admitted for. Obviously, patient's A1C is higher, you would want to intensify the previous regimen, right? If the patient was only on OADs, you would obviously suggest an insulin, right? Otherwise, you might contemplate OADs after complete recovery of the patient. So it finally depends on the patient profile. So finally, to conclude, I think during hospitalization, blood sugar control, we sometimes end up paying importance to everything else, not blood sugar control. I think blood sugar control is extremely important. There is enough data to show it has huge healthcare costs involved. So it is imperative we get the blood sugar under control to improve hospitalization, reduce the length of hospitalization, improve, hasten patients' recovery, and also reduce patients' mortality. So with this, I would like to conclude and thank Dr. Vijayakumar and the organizers for giving me this wonderful opportunity. And I leave the stage for my speakers to follow. Thank you.